Yeah, Dr. Spark.
Hello and welcome to Ask Your Doctor. Now, this is an informative session that is sponsored by My American Doctor. It is not meant to give individual advice or treatment plans for any individual person, but to give you a general idea. For individual advice, you do need to talk to your own doctors. And after you talk to them, if you still have more questions or need further advice or clarification, you can certainly get in touch with My American Doctor, which is a group of highly trained, experienced doctors that represent all specialties that provide second opinion services throughout the country. And our special guest for today is Dr. Sanjay Mehta, who is a highly regarded and very experienced orthopedic surgeon. Well, welcome to the program, Dr. Mehta.
Thanks, Guy. Glad to be here. Thank you.
Thank you so much. So let's get started. Orthopedic surgery. So could you give us a little bit of an idea as to, after medical college, what it takes to be an orthopedic surgeon? What kind of training do you need?
Just like in India, you have to go through a residency program, which means you deal with um, learning about the nuts and bolts of orthopedics, and it takes about 5 years of residency training, which is called residency or house job, as it used to be called, and registrarship in India. And you get to be come out with a degree in orthopedics. Once you've finished that, you're essentially trained in most of the conditions, but then to specialize and to focus your knowledge and your practice, many people do fellowship training, which is an advanced year or two. In my case, it was two, which is in joint replacement and in trauma surgery. And that's when you get to be that, and then you join a practice and start from there.
Well, that's certainly a lot of training. How long have you been in practice now?
I think about 28 years now.
Wow, okay. So the way I see it, orthopedics is kind of like the physics and the engineering of movement. So could you give us a sort of high-end view of what it takes to maintain our bodies in ideal kind of conditions to try and be able to be healthy and move around and use our joints for all our lives?
Well said. It's the science of locomotion in one way, and uh, it's uh, it's the process of life is motion, motion is life, as we say. So to keep you going, um, and to address issues associated with movement is what the science actually. Orthopedics means getting a child. Ortho is straight and pedics is child, so it's keeping the child straight is orthopedic. That's where it came from, but it essentially evolved during the largest or the greatest jump it made was during the wars. So it's almost like a war science in many ways, but it translates into other fields. So generally speaking, there is a skeletal system, which is the core, and the muscles anchor on the skeletal system, and then the nerves, of course, control the muscles, and the muscles then move the bones, and that's how we get going. So that's very simply put the way this whole structure works, or the whole system works. So the muscles atrophy over time, and the biggest problem with muscle atrophy is lack of use. So if you see astronauts in space, they lose muscle mass, as do they lose bone density. So for bone to remain healthy, it also needs stimulus, and the muscles need exercise. So the combination of weight bearing and even your body adjusts to the loads that it is placed on. And that we know, we call it Wolff's Law. which tells you that the stresses or the bone density forms along lines of stress. So, in short, keeping your muscles healthy requires, I won't even get into the dietary aspect of it because diet is, of course, a component. But I think the biggest issue is mobility, staying mobile, staying active, and weight bearing, which also means staying active and moving. Movement is key to this health, along with, of course, diet.
So, especially say in you're telling us that movement and using our muscles and joints is very important. Now, I do know, say that at least in the Indian context, a lot of people tend to sit cross-legged, either on the floor or on a seat. Is long-term cross-leg sitting, is that bad for your knees and things, or does that make a difference at all?
Uh, it's not bad for you at all. I mean, even the Japanese and the Far East people sit in a slightly different posture, and you see elderly people managing that and doing that. I think if you there are some people who are inherently stiff, like their bodies are not as flexible. For them, you need to keep stretching. And the people that are fortunate to have a very flexible body, they need to keep doing it, and it's not at all harmful. I think the
So,
biggest harm is when we, sorry, the biggest harm is when we think that, if we'll do more, we'll damage things. I think that's the problem.
So you're saying that movement and stretching on a regular basis is very important for maintenance of health.
I think so, and I think our Purvaj or our elders got that idea right, and that's where the science of the at least the physical part of the science of yoga comes in.
So from what you see on a regular basis in your clinic, do you get a feeling that in general people are moving and doing less, or do you think that in general people are keeping up with exercise?
I think that's like almost like a socioeconomic and a cultural thing. Because the people that have the means, they are far more attuned to taking care of their health, taking care of their bodies, and they are far more active. Whereas you get into a lower socioeconomic group, a lot of your time is and a lot of your time is trying to just get by, getting day-to-day living. And the second thing is the knowledge is also not as prevalent. So I think that's the way I look at it.
So, of more recent vintage, are there any people like to substitute for exercise and things by saying, is there a pill that I can take? Is there a vitamin that I can take, or some sort of supplement that will help me avoid getting weaker and keep my bones healthy? Is there something that actually works?
I'm not so sure. I think everything in moderation is very useful. Um, a healthy, balanced diet is what I would stay with. Is there one single pill? I'm not aware of it, and I'm not too far researched into the science. There is a science out there where people are looking there's more like a physical medicine rehab or maybe some nutritionalists that are coming out now with different things, but the bone health generally revolves around calcium, vitamin D, is the main thing that I'm aware of. Vitamin C, just a standard, if you're deficient, for example, somebody comes up with a vitamin C deficiency that affects the collagen, that can cause problems. So I think just the um, general vitamins and diet is a balanced diet. Enough proteins is what I would stick with.
Yeah. So we hear a lot about, and we see a lot of people with this condition called arthritis. I know that there are different forms of arthritis, but let's stick to the most common one, osteoarthritis or degenerative arthritis. Could you tell us a little bit about, is this something that we are all destined to get, or is there something that in arthritis that we can do to avoid it? And exactly what is arthritis?
So, starting with what is arthritis? Arthros means joint. Itis is inflammation of the joint. So, basically, it is the inflammation. And what is inflammation? It's a reactionary response of the body. So, your body responds to an irritation in the joints, and that is called as arthritis. Now, the irritation can be from many factors like infection, um, other autoimmune diseases, or osteoarthritis, which is what we will focus on. So osteoarthritis is osteo is bone. Arthritis we talked about. So it's affecting the bones, but it's essentially inflammation of the bones, or the bones make the joints. So it's essentially inflammation of the joints caused by a gradual wear and tear over time. Now, are we all going to get it? Yes, if we live long enough. It's rare. It's rare for somebody to have, but there are different grades. Just because you have some, if the doctor tells you, oh, you have arthritis, but you don't have any issues with it, you don't have any symptoms, then it's like saying you're old, but you say, yeah, I know I'm old, but I'm fine. So I would not worry about it being related to an age. It's a normal process of aging. Now, again, there's a spectrum. Some people get quite severely affected by it, and some people, it does not cause any issues. So not everybody is affected by arthritis. Almost, I will say, everybody gets arthritis, which is a price you pay for living. So the issue comes as to uh, the how much it affects you, and what can be done to prevent it in one way. So, like we talked about, there's a general principles: keep your weight under control. We know heavier people are more likely to get arthritis. There are certain, if you see, many people have, knock knees. They are kind of knock kneed. They're like, when they stand, they have their, legs pointing out. Some people are bow legged. When they stand, they're bow legged. They're more likely to get it. Arthritis of the hips is less common in India. Arthritis of the knees is very common in India. I think all my aunts, almost all of them have it. More, I would perhaps venture to say, I haven't read a study, but it's more common in females than it is in males. So we have wearing away of the joint surface. So if you see, the joint is basically two gliding surfaces make up a joint. And if you take the common example of a knee joint, it's just two gliding surfaces that go bend in this fashion. And when and to make that happen, there is a smooth, shiny lining of tissue that glides on another smooth, shiny lining of tissue, and it glides very nice. It's like a ball bearing. If you look at any nice little ball bearing, you find how nicely machined that is. That's how it is in the human body, except that it is nicely balanced with the ligaments and the muscles, and it gives you a very nicely balanced, stable movement, which is supported by the muscles around the joint. Now, if you keep the muscles strong, then that helps take away some of the load. And that's where bone health and exercise, stretching, they all come in. So the osteoarthritis, in short, coming back, is the wearing away of this cartilage over time, resulting in some amount of, sometimes as it becomes worse, it'll result in some deformity. The biggest issue is of pain and lack and inability to function.
And once you get to a point where you're having a lot of pain, and as a consequence, you're not able to move as much, what are the choices? Is surgery the only answer? Are there treatments before surgery, or what choices does a person have?
That's a good question. So, as we started with, what's bone health, what's joint health? So, to answer to as a corollary to that, the first steps will be to strengthen that aspect, which is physical therapy. So a therapist you can work with, which will help you get mobility back, get your strength back, put you into a regimen, improve your diet, lose weight. All these are, I mean, losing weight, of course, is the what is it, how big an industry is that? Because we know that's the hardest part of it's easy to say, but it's extremely hard to do. But that is a key, because it's just physics. It's pressure is equal to weight upon area, and if your weight increases, you can't increase the surface area, so you're going to have more load on the joint and more pain. So work with physical therapy, or work with reduction of joint, work with improving your diet. And so these factors are the first line of treatment. Now, if this fails, you can add, and at the same time, depending on how severe your discomfort is, you can take over-the-counter medication. Like in India, it's Tylenol, or you can take ibuprofen, or other anti-inflammatories, again in conjunction with your doctor, because if you have issues like heartburn or GI problems, then you need to be careful of that. So that's essentially the first line that you will undertake. Once you
And
have gotten sorry, go ahead.
now I was just going to ask that I've heard of people getting different kinds of injections. Is that an option?
Yeah, so that would be, I would say, the second line. So once you have failed all this and the pain is still persistent, your joint will manifest with pain, swelling, and some loss of function. Like you say, I cannot bend it as much, and it's a little swollen, it's painful. Then the next step would be injection. Now, what do we mean by injection? And I'm kind of referring more to the knee joint as such, because that, I think, is the most common joint we are talking about for arthritis. So the injection is when the doctor places a needle inside the joint and places medicine through the needle, places medicine into the joint. The medicine that we use is a corticosteroid or a steroid, which is a strong anti-inflammatory. And the other medicine is a numbing medicine or a painkiller, which is similar to what your dentist uses when you go for dental work. They inject it, they make it numb, and it acts very quickly, but it acts for a limited amount of time. So it's not like once we put the injection, the numbing medicine would work for 6 months or something. But the numbing medicine helps you confirm as a doctor, as a surgeon, that you are in the correct space, because it works very quickly. So if you inject the patient, and then the patient gets up and starts walking, and he says, yeah, it feels a lot better, you placed it in the correct space, because sometimes that can be an issue. And the second thing is the steroid is like a anti-inflammatory, just like your ibuprofen and Tylenol that you take. Ibuprofen is an anti-inflammatory. Tylenol is just a painkiller, but they work in the whole body, whereas the injection, the steroid, works locally, just locally. So uh, there are oral medications like a Medrol dose pack, which you're familiar with, people take, but I would not recommend that unless you have other issues like an inflammatory like rheumatoid arthritis or something like that. So injection is the next line. And the other type of injection nowadays that we use is called visco supplementation. So there is normally a fluid in any joint to lubricate it. So if you go back to the ball bearing analogy, whenever you have a ball bearing or an engine or a piston that moves, there is lubrication in it. Without lubrication, no two moving parts can move. Now, the lubricating film could be a cell, just a single cell thick, or just like a micro millimeter, but it does need to be there. So similarly, we have in any joint something called a synovial fluid. Now, in a normal knee, in a young person's knee, it is just a small film that lines the surfaces, allowing it to glide. But when the knee gets irritated, the lining membrane secretes a lot of this fluid, and that leads to swelling of the joint. So when the knee swells up, then it is an irritation and it's a formation of this fluid. So there is a normal fluid, and this actually came from horses. Race horses are very prized animals. And so they would start injecting something that has a composition which is similar to synovial fluid. And that is called viscosupplementation. And it's there are different companies that make it, and the concept of viscosupplementation, or injecting the joint with synovial fluid which is like synovial fluid, or fluid which is similar to what is normally present in the knee. And the hope is that that will lubricate the joint and give you some pain relief. So that would be another option, but it doesn't work acutely. So acutely, I would say that I would do the steroid injection, and then that is the next step in the treatment
So,
algorithm.
do any of these things reverse the arthritis or slow it down, or is it just a way of controlling the symptoms?
That's a great point. They just control the symptoms, because the problem that you have is wearing away of the cartilage. So what cartilage? We still don't have the science or the ability to regrow the cartilage, the native cartilage. And maybe not in my lifetime, maybe in another lifetime, all you're going to do is perhaps give an injection either in the knee or in the arm, and you'll inject some growth factors, and maybe your cartilage will start growing. But as of now, the fundamental problem is that you have lost cartilage. And then once you lose the cartilage, that's not coming back. But the symptoms that are associated with loss of that cartilage is what we are dancing around. And by the first non-operative or non-injection measures, like losing weight is one of the critical things, because it does put a lot of load on your joint and leads to this problem. So that's a good question. I that you that doesn't happen.
So, as of now, there is no way to regrow cartilage, and there is no cartilage transplant or anything like that.
Yes and no. So cartilage transplant does take place. We do it in so again, arthritis is generally an older person phenomena, but if you have localized lesions or localized areas, small areas where the cartilage is damaged, especially in athletes and younger people, in them, yes, you can do localized cartilage transplantation, but
Mhm.
not for the because again, the issue is that when you have a younger person, there's a localized area of injury, whereas when you have arthritis, it's like a diffuse area of wear or loss of cartilage. So just taking a large chunk of the cartilage off is not really possible.
So then what you're saying is for small localized area in younger kind of patients, it's possible, but in general, for most people with age-related osteoarthritis, it's not an option.
That's very well said. Yes, absolutely.
So ultimately, people have tried this and that, and it's still not helping, and they're still very incapacitated. So I suppose at that point you'll recommend a joint replacement.
Yes, before we jump on to that, just another word on these non-operative measures. There are people out there who believe in stuff like using MRIs, doing other kind of procedures. Most of them are unproven and not widely accepted. So there will be people that will advertise, and they will say we can do, say, MRIs or some magnetic energy or other stuff. Um, they are not mainstreams, and it's anecdotal, and they are expensive, and I don't think you will see much benefit. And they're all out there, and we, because it's such a common problem that we are all working to find an answer. So people sometimes are clutching with two straws, and but remember that your chances of success with them are low. Moving on to now, you started with physical therapy. You did that for a couple of years. Pain got worse. Then you went back and got an injection. Injections now, if I got an injection in my knee and it helped me for a year or maybe 2 years, maybe longer, and my knee starts hurting again, I can always get another injection. And if it lasts another 2, 3 years, maybe I'll get another injection. So injections are not a one and done thing. It can be done serially. And depending on how much response you get, because if I get the injection in my knee and my pain just goes away temporarily and comes back within a week or two, then it's really not helping. And if I get another injection in 3 months and it doesn't help, then I think you know that it's not going to go well with injections. So that's when I would stop the injection train and track and then look to other options. The most lasting pain relief that you can get and the most effective way of relieving the pain is certainly a joint replacement, but only when you have failed the other options. And also, you should be a candidate for it, meaning ideally you should lose weight. Ideally, you should not have other medical comorbidities like diabetes. The worse your diabetes is, the higher your risk of infection. And we do check hemoglobin A1C levels before we embark on that road, which is a measure of your long-term glucose control with diabetes. So the diabetics, the biggest problem is that they have higher blood glucose levels. And so you need to have that under control. You have to have your medical doctor manage that. And once you got the other issues can be like if you have kidney failure, liver failure, or other organ issues, the more organs that are affected, the sicker the patient, the 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 more the complications associated with an arthroplasty. So it's like preparing for a race. If you're going to get surgery, you get yourself readied for it and you work to make sure that you're healthy enough to undergo the procedure. And so, yes, and you also need to understand why we are talking about a joint replacement. And that is, the issue is that the cartilage is worn away. We're not getting it back. So an arthroplasty is basically, arthros, we said, was joint, and it's a plasty or changing a part of the joint or resurfacing the joint is what a knee replacement is. It's essentially you're changing the lining mechanism. So instead of cartilage on cartilage, now you have metal on plastic, and they both are fixed to the bones on either end, and that's what takes away the pain, because now you don't have the bone rubbing against bone or the worn cartilage inflaming the knee joint. So that's how it works. Aligning it correctly and getting it fixed to the bone, it's as simple as that, and you're good to
So,
go.
okay. So if somebody is considering getting their knee replaced, does it last forever? Does it last for 50 years? How long does an artificial joint last?
Uh, so I've seen them out. I think I would say about 20 years at least now with the older joints. Every time we say that these will last you longer, we have, they're we don't know, because we haven't. If you get a new joint, it hasn't lasted for 20 years, so you don't have the data for it. But I would say with even older joints that I've seen in my own experience, uh, many young patients can easily go to about 20 years, maybe longer, because the big issue is with the joint. So looking at it in another way, why does a joint replacement fail? So the commonest is, in the short term, the biggest issue is infection. So if your wound heals and incision heals and you get past that 3 month, 4 month, 6 month mark, Generally, so now infection is out of the picture. Now the question is, was it put in correctly? So you can have issues like it was not aligned properly. So that can result in something called as instability. And the patient may say it just does not feel right. It gives way or it just does not feel right. Now, assuming that you have put the knee in correctly and you have escaped infection, then the next issue becomes the so one other thing will be, of course, physical therapy and stiffness, but that's a different issue. So we are talking about infection, we are talking about instability, and we're talking about fixation of components. So nowadays we have something called as so in the past it was common to use cement, and it is still the gold standard that you use bone cement to anchor the components on each side. So you anchor the femur, you anchor the tibia, and they get fixed, and then you can once they are fixed, they are put in correctly, and you have escaped infection. Then they should last you for a very long time. Now, as you get longer and longer, the factor that comes into play is called the wear of the plastic, or it's metal on plastic, and the plastic can eventually wear with time. Now, we are coming up with newer plastics. We believe they will last longer, but that's the factor that's the one that comes into play as the arthroplasty stays longer and longer. And if we are able to solve that and there is no wear, then theoretically it can last you for a very, very long time.
I guess one of the things we didn't mention, but I'm sure it plays a big role in this, is smoking. Does smoking have a deleterious effect on all of these things?
Yes, smoking does interfere with wound healing. So we all know as surgeons, the biggest issue with smoking is small vessel disease and vascular issues. So smoking causes, especially as you go distally in the extremities, the smoking causes vascular problems. As far as we are concerned as surgeons, we are not treating lung disease, and that's a different issue altogether. And of course, how it affects your pocket, that's up to you. But biggest issue for us is the small vessel disease, which interferes with healing, and that leads to infection or wound healing problems. And once you get an infection, that is a terrible complication. So finding out patients' blood sugar, finding out their heavier set, because the bigger the tissue you have to cut through, the more the chances of that tissue not healing, as you're well aware. And then the healing process itself, if the blood vessels are compromised, then that's the issue. So yes, smoking, this if you're having a knee replacement, you can help yourself immensely by cutting smoking, losing weight, and keeping your blood sugars under control.
So, assuming somebody has done those things, they have either never smoked or stopped smoking, they have lost weight, they're exercising and following a good nutrition, the overall success rates and the happiness of the patient after they have recovered from a joint replacement, generally speaking, is quite good.
I think it is excellent because a surgery like this in the right patient, because let's put ourselves in that situation. I go to work and I'm having knee pain and I'm having difficulty walking. I'm having difficulty getting from my car to, or I'm having difficulty standing during the day doing my surgery. And then I get physical therapy. I tried that for 6 months. It's still bothering me. And then some people are very active. And then after 6 months or a year, I stop taking any walks or exercising or whatever it is. I can't do it. I get an injection, still doesn't get there. So depending also about but by now your x-rays also show that you have worn away the cartilage, you have deformity, you have this arthritis process. And if you failed everything, then you should be, in my opinion, this surgery should help you immensely, assuming you get past all these issues that can be a trap.
At some point, do you tell a patient that they might be too old to undergo the surgery?
So old means there's a chronological age and there's a physiologic age. So you can have a 55-year-old or a 60-year-old who's in terrible health. Just you look at him and you say, sir, who's got who's a smoker, it can has an oxygen and is in a wheelchair, and he's got diabetes, and he's not a good candidate for it. Now you have a, and nowadays we are seeing more and more of it. You have an 85-year-old who comes in, goes for a walk every day. I have had, in fact, 2 weeks ago in my office, I had two 93-year-old people, and both walked in. One was using a cane, one came in without a cane. Now, you know, and the 91 had a hip replacement. The 93-year-old, I think, had a fracture that healed. But age is a number. So it is physiologic age over chronologic age. That's the way I look at it.
So then, from my summary, from the things that you have said about joint replacement, and I will take the knee joint as the standard and the most common joint that people have trouble with. And I'm sure that there are technical issues and individual differences between these various other joints. But for the sake of this discussion, we'll just use the knee joint as our standard. So overall, I think from what you said, it is very common for people to develop this, particularly in women, and that if all else fails, that they should not be hesitant to consider all the various treatments that you have so well explained, and that even if they need surgery, they should not be scared of getting it because the results are excellent, generally speaking.
I agree. That's a good summarization. Yeah, you go through the algorithm, go through the treatment phases, and there are so many people that will be happy with just uh, little change in lifestyle, change in a little bit of diet, losing some weight. There are a bunch of people that will benefit with that. Some people can be treated for long term with just injections, and then surgery is a very viable option. It works well, and you should be a good candidate. There are complications with it, but it does give good lasting pain relief, and it can last you for a very long time and give you a very functional and a happy life.
Excellent. I'm not sure we have enough time to discuss each of the other joints, but to try and look at it from a mile high view, is it accurate to say that even now, even though more recently the smaller joints have also started to be replaced, such as the joints in the fingers, the joints in the wrists, perhaps, or I'm not sure if there are joints in the feet that can be replaced, but in general, do smaller joint replacements work as well as larger joint replacements?
They do work again in certain indications, and we are replacing joints, like the big toe, the base of the big toe. There's arthroplasty there, ankle joint, then those are the common ones that we do, and in the wrist it can be up to the wrist, even some finger joints like you mentioned, elbow joints for certain patients. I think the the reason we talk about hip, knee, say even shoulder is very common now, because these are the commoner problems, and we have more experience with them. The others are done by specialized doctors, whereas hip, knee, shoulder will be more common. Elbow is getting common too, although there are issues with the elbow. But I think in the correct indication, um, and getting the correct person and the correct indication or the reason for doing the surgery will give you good relief, and it will work well for you.
Well, in the time left to us, I'd like to cover another problem that I think you see quite frequently, and that is fractures, particularly hip fractures, which seem to be very common, I think, in all countries, I'm sure, particularly in India. Could you tell us a little bit about hip fractures in older people and what the options are if, say, somebody is elderly, parent or grandparent falls and breaks a hip, what options do they have?
Yes, well said. Because just like we use the knee as something to build on and talk about all around it, similarly, fractures are in the younger population, and those are high energy fractures. Like somebody gets hit by a motorcycle or falls or car accident and or falls from a height. So those are high energy fractures, mainly in younger people. And then there are the so-called fragility or lower energy fractures in older people. So now if you have a person who is even 60, 65, 70, or whatever it is, the issue is what force was exerted on that patient when he fell. For example, you have a person that falls down an entire staircase, like we have apartments in India. And if you're walking up an apartment like a flight of 15 steps and you fall down, that's more energy than somebody who trips at home and falls. So just remember this sort of broad uh, uh, classification or distinction. And coming back to hip fractures are very common all over the world, and it gets commoner as we get older. You see it in the elderly, and that's why many of them are called fragility fractures, because the bone is already fragile, as is the person. So when they fall, then they commonly break something. And when they break something, then the goal of the treatment sorry, is to make sure that the patient can be up and moving. If you put a patient, any patient, especially an older person, put them on the bed and tell them not to move, that is a great disservice to them and also decreases their ability to survive that injury. So whatever it takes, if the fracture that they sustained is a stable fracture, then they should be up and about. If the fracture is unstable, then it should be fixed or treated surgically, with the goal of the treatment, whether surgical or non-surgical, is to get the patient off the bed and standing and walking.
Are hip fractures in the elderly, just as you mentioned, the fragility fracture, are they very painful?
Yes, they are painful, and that's the other problem you have, that it's the surgical treatment sometimes is only done to alleviate pain. I always say this to my patients. I said, look, if you say we don't want somebody to have an operation, then how are you going to treat the pain? With medicine? But medicine, that degree of medicine that you need to take away the pain completely, will almost upturn the patient. So if you turn a patient, for example, to clean them, that's very painful with a hip fracture. All right. So we you need to do multimodal treatments. You need to be more aggressive. But that's, again, I'm a surgeon, so that's my take on it. That be aggressive. Um, don't treat them as uh, as as somebody that you don't need to do anything, or he'll be all right. Get them up, give them a chance, and most important thing is mobilize activity. Get them up, get them sitting, get them standing, get them walking.
So, from what you're saying, is it fair to say that if somebody says my father is 85 years old, he fell, broke his hip, and is in severe pain, any small amount of movement gives them a lot of pain? Uh, but I'm worried because he's 85 that he's too old to have surgery. You would actually say that it is perhaps safer for the person to actually have the surgery done so that they can have less pain and be mobilized rather than to do what the patient's family may think is safer, but actually is not good for them.
100%, very well said. I couldn't say it any better, that surgery is your only way out. If you don't operate, I mean, I'm talking about an unstable fracture that needs surgery. you waiting for it or saying that age, because he doesn't have that much time. Now, if you lose that time by trying to get him to get better, tying him down to the bed, it's I I think that's doing a disservice to the patient and to yourself. It's there is the problem, we have this phobia of surgery, but it's like, I almost say this, it's like your house is on fire. Sometimes it's as bad as that, right? Your only option is taking a chance outside than staying in. And that is only if the patient is an extremely high risk. But generally, they're all a little bit higher risk than a 20-year-old. They have to be. And, but, the goal is get them up, get them going, get the operation done sooner. In the US, it's the criteria is within 24 hours. In fact, you need to get these people operated upon, a patient with hip fracture. There's I think it's Medicare mandate that you do it, and then your reimbursement to the hospital is based on that too. And there are committees in every hospital to optimize the patient, change what you can change. There are some things that you can change in a patient, like their electrolytes or something like that, or reverse their Coumadin, but get them optimized, get them to the operating room, and then mobilize them.
And generally, in your experience, even in this elderly, fragile people, the results are quite encouraging.
I think so. Again, it's what you put in is what you're going to get out. So if you have an extremely sick patient before and you're doing the surgery for pain relief, then it may be a different issue, because if the patient was bed bound before, and they have a fracture that can only be fixed surgically, and your goal then is essentially pain relief more than function. But I think otherwise, there is no other option that you fix it, you take care of it, relieve the pain, get them up, get them moving sooner, the better.
So, Dr. Mehta, you've covered a lot, and we've all learned a lot from this session. I'd just like you to maybe look a little bit out into the next 5, 10 years and try and give us some ideas. Do you see any major changes coming from new technology, new ideas that you think might change what you do over the next 5 to 10 years?
5 years. No, the biggest stresses, or the biggest focus now is preventing a lot of it. So I think that there was a generation, perhaps my father's generation and myself, where we just focused on making a living. But now the trend is changing, where people are trying to focus also on their health. And so I think that if you spend time on your body, on your health, that is as critical, or perhaps more important than chasing financial security, which is again got nothing to do with medicine. But I think that that's where the key lies. And as far as technology goes, um, we are we are perhaps advancing on two fields or two sides. One would be um, medicine to get the bone stronger, which there is the medical doctors will focus on. And as a surgeon, my interest lies in different modes of fixation, replacement, and earlier. So we have come a long way with fixing fractures also, like the implants have changed, they're stronger. We get patients up, we get them moving. We do replacements for fractures around the knee. We do replacements as we realize the bone quality is not good. In the past, we would try and fix them all. But then we realize that we are trying to fix something which has very poor bone quality. So the fixation doesn't hold. You're using good implants, but it has to still anchor into something. So that has changed. Now we are able to get implants that are, and arthroplasty has also changed. We got different ways of fixing in bone. We're doing it a lot quicker because the training is better. But that's kind of sort of where we are at this time. I think I think the next evolution will be the genetic aspect of it, and the dealing with the bone quality, and hopefully someday regrow cartilage. And maybe an injection will be there that helps just heal the bone instead of cutting somebody open. And so I look forward to that. Hopefully, I can live to see that.
Well, thank you so much. It's a very informative session. I greatly appreciate your spending time with us and sharing your knowledge. And for people who are listening or viewing this, please talk to your own doctors about any issues that you may have. And if you wind up deciding you'd like a second opinion, the doctors from My American Doctor are available to you. You can make an appointment with any of us for further information. Thank you for attending this session. Best wishes.
Thanks, Kai. It was great.
Thank you. Thank you. Uh,
How do we get out of this?
how is